everyone, and welcome to the next session for our Australian Sickle Cell Advocacy Conference 2021. Thank you so much for joining us, and we're excited to bring you our next presenter and guest speaker for the day, Professor Baba Inusa. My name is Shane Rao. I'm a patient advocate living in Queensland in Australia, and looking forward to our next panelist and next sessions. It's been a wonderful session and event so far, and promises to be even better as we go on. So I can see we have Professor here with us. Welcome Agnes and everyone else who is wonderful. Thank you very much for joining us. Agnes as well, thank you so much for joining us. And also Agnes, thank you for these opportunities, for putting all of this together. It's an amazing event. So just very quickly, I'd like to introduce Professor Inusa. So the professor is affiliated with the Guy's and St Thomas's NHS Foundation Trust. Professor Inusa is also a professor of Paediatric Haematology from the King's College in London. And he's also the chair of National Hemoglobinopathy panel. And he also chairs the National Multidisciplinary Meeting for Complex Patients at the high cost drug panel in England. So Professor, without further ado, we'd love to hear your presentation. So the topic is transitioning from pediatrics to adult care. And that affects so many of us as patients, as warriors. And so we'll get straight into it. The virtual floor is yours, sir.
Okay. These are my disclosures. Obviously, good morning from London, and I'm not sure exactly what the time is for you, but I thank you for waiting to listen to me. And thank for Agnes and the whole organizing committee for making it possible. I know that with the pandemic and the fact that we can do a lot of programs virtually, it gives us opportunities to do a lot of programs, but also it gives us challenges how to deal with these ones, because we have so many programs that we're dealing with, and you have so many people actually asking you to participate in this program. So I know it's taking you quite a while to decide who to invite, and I think it's a privilege to be here. Transitioning from pediatric to adult in general actually is a major challenge. It's a challenge because you have pediatricians, or you have services that deal with children, and you also have services that deal with adults, and you have adult clinicians, but there's always a gap, because how do you link these two services together? It should make sense to basically automatically expect that the pediatrician should be prepared, that the adult is going to take over, and the adult will be the same way. But we know that even service provisions like social care and welfare services, they deal with people, the community estate, they say, yeah, automatically you're not an adult, so take care of yourself. And you're left to systems, you're left to your family to deal with the fallout from that. And therefore, looking at definitions that by the Department of Health, for example, in England, which says transition should be a purposeful, planned movement of adolescents and young adults with chronic physical and medical conditions from child-centered adult to adult-oriented healthcare services, or and by definition, a guided educational therapeutic process rather than an administrative event, allowing for the broader developmental changes of adolescents than just a clinical need, because it's not just basically transferring the insulin management from the parent to the child overnight who becomes an adult. And we're looking at sometimes you have a number, and the number will be 14 or 16 or 18, depending on wherever you are in terms of the years in which you transfer from pediatric to adult services. And should we just basically say, okay, you're now 14, so you're now an adult, or you're now 16, you're now an adult? So it just give you a transfer note to move on. Actually, this is what happens in a number of countries. I've reviewed a number of services in different across the world, and some countries, yes, you are 14, you are an adult, and some countries you are 16, you are an adult. So things, they just basically the administrative officer writes a note and gives you to go to the next service. And we should expect that services should be better than this. And so, what are some of the issues? Some of the issues, the people transferring from pediatric to adult services, some of them say they are very scared, and they say, well, you start to worry about what they are probably going to give you. They're going to give you the wrong medicine. Are you going to trust those people you are going to go to? But actually, I have experienced a patient telling me that, look, you looked after me for 17 years, and you just want to basically say to me goodbye. And we had to respond to that by developing a model that actually allows us to have a kind of a smooth way of saying goodbye. And when they go to adult services, they come back to you and say, okay, could you please send me a letter to send to my employer? And I say, well, but you have an adult consultant. And they say, well, you've known me much longer than the adult consultant has known you, so you can say much better about me than they who actually I've just met over the last 1 to 2 years. There is some wisdom in that, but the issue is how do you actually make this transfer smoothly in a way that other people can really have the same information that we have and transfer it to them, because the adult clinician is also kind of disadvantaged because he's just meeting this person for the first time, doesn't understand all their various issues as well. So it is something that is important to be able to really have a very clear plan, and it involves communication not only from the pediatric but also from the adult, and not only from that but also from the family. And what are some of their fears? Is they wanted to be like the fears of adolescents, and then they kind of mistrust adult services, and have issues with access to care. And adult healthcare services are not the same with the pediatric services. If you are in adult ward, you have to kind of really make sure that you get the nurse attention. You're in a pediatric ward, the nurses actually look for you and ask you, what do you need? What should you give you? And this transfer, this movement from the pediatric services to the adult care is actually can be very chaotic. And this is so what are some of the barriers? So if somebody actually does not really understand their diagnosis, and which we have found, particularly in sickle cell services, some people actually do not know the difference between hemoglobin SS and hemoglobin SC. And some people actually think because they have hemoglobin SC, they don't have a full sickle cell disease, they have a sickle cell trait. So what we need to try and do to actually help them is to help them to understand their diagnosis, and also to understand what will they need actually to deal with these challenges that they experience on a day-to-day basis. And so when you're talking to families, you meet the children and you talk to the parents, but somehow you actually talk to the parents and actually the child is basically not involved in that discussion. And so really they have not really owned up to the fact that it is their care. Again, you have emerging organ damage. The kidneys probably begin to have problems, or maybe the patient has had a stroke and they have some limitations either in communication. And how do we deal with those communication? I have had experience of a young person who actually could not even go to next door to buy something. And we had to take them through a kind of a process whereby they begin to be able to learn to move from one street to the next street safely, but under guidance. And sometimes really having somebody to actually guide them through that process, not just the parents, actually will help them to deal with some of those things. And so we also need to have adults that are trained in taking care of young people, and listening to them. My transition notes actually used to have all the numbers for these young people, and they will call, they will talk, and they will talk in the language that actually they understand and they actually appreciate. So it's important to look at the various barriers and how can we deal with those barriers. And how to deal with this is actually very different depending on the location as well. The issues may be similar, but there are also subtle differences. And also when you look at differences between low income settings and high income settings, there are issues that some of them are actually access, some of them is actually availability, and some of them is the cost. How can we deal with some of the things? So I thought maybe it would be useful to go through some of the models that were actually indicated in our paper, in the Lancet paper, and I also have various authors who have been very, very kind of powerful in the work they've been doing. This is one of the models that is used in the United Kingdom, which is called Ready, Steady, Go. Ready, Steady, Go is to help the individual young person to understand what their care is about. What is the plan for their own transition? They will ask the question, they should ask the question. But actually sometimes it's a difficult question to ask because really they don't feel ready to do that. And so in some patients, you mentioned that now that you have finished your secondary school examination or GCSE as we have it in the United Kingdom, we should be thinking about moving you to the adult service and then ask you, what age should I move? If you say, okay, the range is between 16 to 18 years, they want to go to the last bit that is available, that is up to the 18 years. But even then, when it comes to the 18 years, they begin to wonder, why do they have to move? Because they feel insecure and they feel that they are going to a service that actually do not understand their needs. And they want to know, okay, can they remain under your care? So we need to kind of help them to understand some of these things. So, and they should be encouraged to ask this question. Can I visit the adult services to look around? Can I meet the adult staff? And I think meeting the adult staff should not just be in a clinic setting, which is the usual model, whereby you have the pediatric and the adult services meet together to see the patient over 1 hour or 1.5 hour duration. And you expect that all of them should develop the confidence that they should move to adult care, and also that the adult should know exactly how to deal with the challenges that a young person has. I think it needs to be beyond that. And that is why the Ready, Steady, Go comes up in different colors. And just the getting ready, basically the initial part comes in this red color, and then there are subsequent differences in the colors up to the green when you are ready to go. But the questions that I ask are actually very similar. You want to know about their knowledge of their disorder, and also what is their ability to actually advocate for themselves. Can they probably really defend their need or explain their need and not really get very frustrated? And also, what are the health and health lifestyle that actually they should be deal with? And these are the things that you're trying to help them to understand or daily living. Some actually will have a limitation of actually taking care of themselves. And that is why it's important to make sure that there is service provision that provides access as well. And in terms of school and their future, and again, it can easily come to a point that actually we just look at, can they take care of themselves? Can they have their ability to look after themselves? But actually, they also want to deal with issues like leisure, and they also want to think about relationships. But these are things that we actually probably could basically not attend to because we are really kind of fixed in the fact that we want to make sure that they are safe and they are okay. But actually we also need to think about what are their individual needs. How do we assess readiness for transition? And so we have used also a similar model to do Ready, Steady, Go. We use it as a passport, and the passport has different themes. And those themes, we assess them in terms of numbers to see if it's 1 and they just basically have very little awareness of there are diagnoses that sickle cell disease is associated with jaundice, and jaundice is because of hemolysis and because of inability of the system to clear the bilirubin. But actually, some of them I think that once they see jaundice, really things are very, very bad. It may not be completely untrue, but at least they need to understand why that may be a factor that suggests probably a severe or hemolytic process. So we need to help them to understand that. And some of them take penicillin. They don't know why they take penicillin. They think that penicillin is the one that reduces pain. Because the parents are taking a full responsibility of doing that, and the young person has not had the chance to actually look at those things. So these are the things that we try to assess, and we use that to see where they are, and to also understand the areas that we need to pay attention to. And some of them may just be the diagnosis, some of them may just be taking care of themselves, but actually some of them may be the lifestyle, and so that you're able to actually concentrate on that. And I think it's not just a medical model in terms of doctors and nurses, psychology, mental health workers. I think they are very, very key in dealing with young people and helping them to navigate the issues and the challenges that are actually going to happen. And we also have to look at areas that have to do with gender. And then also make sure that when we are doing offering the services, these services taking account some of their peculiar needs in terms of gender-specific areas, and what is it that really, really kind of matters to them. And that's why really having this as a team and having a team that actually covers and understand all the different aspects actually can make it work. I have found that really involving psychology, nurses, as the center and the core actually makes a lot of sense, and it has helped us to actually understand some of the issues that young people are dealing with. And the Canadian model, again, which is the patient navigator, is very, very, it's something that I have found that actually looking at it is a very good model, a very interesting model. Again, but it's capital intensive. Can we have a patient navigator for all the services? Sometimes we're struggling to have the nurses that actually deal with just the standard practical care of day-to-day in the hospital. But we need really to have a dedicated transition service that actually would have something like a patient navigator who would be the one that the patient can identify, can recognize, can actually communicate their needs, and that this person will be able to identify some of their complex and tailor the support that the individual patient needs to very kind of to meet their expectation, but also to meet their needs. So I think different models are actually very, very interesting. And so not all patients will require a navigator, and we have to identify those who are most at risk, particularly when you think about a patient who has multiple stroke, or maybe a patient who has significant social instability and challenges. We can have, this ones actually would definitely need a patient navigator if it is at all possible to provide it. And really assessing the transition readiness and reassessment is also very, very key. And really reassessing them, but not only reassessing them, but making sure that we can provide support and training or teaching to help them to be able to actually move on. And when you come back for a reassessment, at least you could see the progress. So adolescents value trusting relationships with healthcare providers who offer adolescent-focused information and discuss aspects of their lives outside of their illness. Because sometimes a young person tells you that, well, my life is not all about sickle cell disease or about thalassaemia. And to some extent, that should be true. So we should help them to actually see themselves as individuals that have needs, and how we can meet some of those needs. And then, so the social ecological model of adolescent and young adult readiness to transition, which is the SMART model, and they look at some of the pre-existing factors, such as some social, demographic and cultural issues, the medical status, and their ability to really connect, or in terms of neurocognition, intelligent coach. I mean, this, if the pediatrician has most of this information, and we actually use this information to help us to modify the various factors that actually we can help them with. And I like this model because it talked about modifiable factors and factors that actually are very difficult to modify. So the like pre-existing factors like medical and cognition, these are things that we really can't do very much about, but there are certain things that actually we can help to change. The knowledge we can help to change. We can help them to understand in terms of self-efficacy. We also can help the health beliefs models, and these are the things that actually we need to kind of work on to try and help them to deal with how do they manage pain, how do they navigate the healthcare services. In some countries, the young person has to manage their appointments, manage their treatment, whereas other services, they just make sure that they can make themselves available to various services. So these are the things that needs to be able to take into account. And so, like this is, I like this quote from one of Jalen Porter's patients, who says, "What does transition look like?" What he says, well, it's like him. I look like a successful transition. I function on my own. I live on my own. I have my own means of income. I have my own transportation. So I mean, what else more is there to do in adulthood? What more successful can you get? And so we try to actually summarize the recommendation in the paper that we wrote, that the Sickle recommendation, S standing for skills transfer, how we worked with them to actually transfer some of the skills that the parents were dealing with, some of the things that really somebody are helping them to do it. We need to kind of help them to really, really be able to say, okay, they can deal with appointments, they can deal with organizing their transportation, they can deal with their work, and they can actually find employment. And so actually in terms of employment, we actually had a book in terms of which helps the young people to know what number to call and to know how to actually kind of submit their applications and everything, but also how did they deal with their new employer. These are things that it's important to look at them. And in terms of increasing self-efficacy, managing their pain, again, really that they take responsibility about their own health. And those are the things that we need to really kind of help with. In terms of coordination of the transition, coordination of the transition, I find it much easier and much more functional for nurses to be, at least in our own service, to be the core person that actually puts that together. But the person needs the time and need the support and need the recognition so that they will be able to actually provide this. But the coordination can be anybody that actually is very key, just like the Canadian model that said the patient navigator, and then looking at the knowledge transfer. And so that these are the things that we'll be able to assess and say, okay, these are the things that you need to kind of work on. And linking the individual to adult services, there are various models. Some of these models could be, it's the same service, which has a pediatric and an adult care. So they are really not moving hospitals if you're talking about the hospital management that they need. But actually in some situations, they have to move to a complete different setting, different systems, different hospital, and really it's new. And so all of those things, if these things are new, we need to make sure that the young person is able to engage in them. But also the role of the parents. The parents need to engage, to accept that this is something that will meet the need of their individual child, because the parents actually do understand and do recognize the needs of the patient. Although we know that as the patient transfers from pediatric to adult services, we want them to be a bit more independent, we want them to be able to take their decisions. But again, it's not easy for parents to completely just relinquish that connection that they've had with a young person right from very early on. And they are also worried about the fact that the young person is going to a service that actually is new, we can't just automatically say the parent doesn't need to engage with them. So we need to reevaluate their readiness, not only in the knowledge, but their readiness also in self-efficacy, and their readiness in terms of the skills that they have to deal with some of these issues. So I think transition is such a kind of an area that actually is quite, I would say to some extent, poorly attended to, not only in low-income settings, but also in high-income settings. Provisions sometimes are the Cinderella of the service, and if, for example, you have a transition nurse or a transition pediatrician, doctor, that person can be drafted to actually work in other areas because those are the areas they deem to think that they actually have more acute needs. And also, what is the role of parents in all of this? What is the role of parent-patient support societies? I think this needs to really kind of continue to deal with the issues and the gap that actually are there in transition. And also, it's not only a health model, but actually involves education and it involves social care as well. So I wish to once again thank Agnes and the whole team for making it possible for us to discuss the issue of transition. I welcome comment, I welcome questions, because it's a topic that, yeah, you can talk a lot about one aspect. We talk about the psychological needs, we can talk about the medical needs, we can talk about how to deal even just with really helping them to adopt a lifestyle that will help them to actually fit in society. Thank you for the opportunity again for discussion, and I would like to welcome any questions and comment. Thank you, and good morning.
Thank you very much, Professor. That was absolutely informative, very relatable for so many of us, because we've all been through that transition phase as warriors, and it's great to see it in this fashion where there in many cases this transition it works, but I guess there's no one sort of uniform way of looking at it. So, that the Ready, Steady, Go program, I think it's fantastic. Professor, we have a couple of questions. I'm just mindful of the time as well, but we do have one question here that we got asked, which was, why does care change so quickly and be aggressively suboptimal?
Like I mentioned, sometimes we just think about the young person just has attained an age. You say, okay, they're now 16. And you just say, well, they should move. And they move because the services have not been prepared to actually, they don't even have the time sometimes to meet with each other to discuss the issues that a young person is dealing with. And also, the parents had not really reached a point that they actually been able to discuss some of these diagnoses and challenges that the young person would face. The community I deal with, parents sometimes say, okay, my child is not yet old enough to actually hear about their diagnosis. So I've had a patient that I've attended my clinic up to the age of 16, and the mother has not said to them they have sickle cell disease. They just give them the medication and makes the child to take the medication. But the patient knew the diagnosis, but the mother didn't know that the child knew the diagnosis. So I think it's a multi-dimensional issue, and we need to look at what the parents can do, but also what the services need to do. And that's why pediatricians, we have to talk to the patients rather than just talking to the parents alone.
Wonderful, thank you. I think we're just out of time there.
Thank you.
Professor, very, very much gratitude for your time and for presenting this session. Agnes is going to say something as well. So thank you, Professor.
Thank you.
I just wanted to say thank you, Professor Inusa Baba. Is it still here?
Yes, I'm still here. I'm still here. I'm still here. Thank you.
No, we just wanted to say thank you so much for being one of our keynote speakers and presenting this important session. I know we have so many questions that maybe we'll send you through. The issue has always been the level of care between the young, the teenagers or the pediatric side to the adults, it's a gradual, it's actually an abrupt change, not gradual. It's an abrupt change straight from, pediatrics, and then you go into this adult ward where, and, I'm looking at this from the people that are affected by this condition mostly come from an African background. And we know from, the African setting, a child is, a child in your home until they get married, doesn't matter what age. But you move from 16 and you go to the adult hospitals, the parents are not even allowed in. And I feel 16 is quite young, to be honest, to leave a 16-year-old to fend for themselves. Is there anything that, like you pediatric clinicians, we've got Dr. Greenway here, also is one of our doctors here, can be done apart from, having these strict restrictions where like a parent just have to, leave it to their child to look after themselves when they go to the adult hospitals?
I'll be quick. So what happened is that we've been to the looked at services. The Middle East, for example, 14, you're an adult, you move to adult world. And so basically what Bahrain have done is to, when you move to adult world, then they will have the pediatrician to still be your consultant. So you find out that you just become 14, you must be an adult. You cannot be in the pediatric ward. And the services also have this very strong demarcation to say once it's 16, the nurses actually won't let you even admit that patient in the pediatric ward. You have to be really very, they must accept your kind of idiosyncrasies to be able to allow your patients to stay sometimes in the adult ward. But I think we can somehow improve this by continuing to increase the level of communication that we do with our young people, but also to try and provide services that are not necessarily hospital dependent. So doing a clinic, for example, outside of normal working hours, or maybe within a community setting, would actually help the young person probably to relate much better with us. So I think it's probably multimodal, but it's something that is not just determined by the pediatrician. In fact, if the pediatricians have their way, we can keep them much longer.
Would it be something that you can consider from like an organization level, like the Society, Hematology Society of American Society, Australia and UK, where you make guidelines strictly to say a 16-year-old cannot fend for themselves? Maybe 21, 18 even. 18 is better. We have Isabella here has got 2 children. Isabella, any thoughts? And sorry, Shane, it's okay if you leave because I know you are wanted the other side. So it's okay. We'll finish off here. Thank you, Shane.
Yeah, I guess the transition itself from young children, I agree with you, Agnes, not all children, not all adult children even take ownership of their condition. So they don't really know much because they've been relying on their parents the whole time, from the research the parents have been doing and actually, speaking on their behalf. So a lot of children, even young adults from the age of 18 really don't know very much from their condition. And that's just speaking from an Australian point of view more than, from places around the world. So it's quite interesting that, when do you think that young adults take ownership of their own condition when parents are still there with all the information in their head? Still till now, some, my kids, not so much my daughter, but perhaps my son, who really goes, oh, you should ask my mum, she knows all the information. And he's 28 years old, Baba. So when do they take ownership?
I think it's that is a bit of a gender issue as well, because young people, young men tend to come to my clinic and they don't say too much at all. You ask a question and they don't answer you. They just look to the mother to respond to on their behalf. And I think probably it's engaging them directly, as mentioning their names and challenging them, or basically say, okay, I'm going to talk to you now. don't worry, I'm going. And then, so when I start talking to the young man, you know what happens to the mother? The mother answers the question. I said, no. So
Right.
I'm going to come to you, mom. So I said, okay, let me just finish with the young person. And I think really for them to begin to recognize that they are taking responsibility for that. And I think I start talking to them before the age of 10. And I think it's important to continue to talk with them because you'll be surprised about the ideas the young people can give you. And to some extent, actually, the gender aspect is true. So in fact, the young women tend to actually always really take charge of things and begin to talk to you. So I think it's something that we need to really help the parents not to be the one that answer the questions all the time. But again, you have to be careful not to make the parent feel they're not wanted. You also not want to make sure that the parent does not become disempowered because you've actually shut her down or sorry, I didn't say, I said her because mostly it's the mother as well that comes, not necessarily the father, but actually make sure that the parents' views are respected because sometimes our parents, my patient's parents, they come to a stage that they begin to think the young man is actually being disobedient, but actually try to encourage them. Actually, they just basically is their development, and you should welcome that rather than thinking that they're actually opposing you. Because right. The young person says, and you can see them actually squabble in the clinic, and sometimes it's healthy.
But you know, one of the things that worries me, Professor, is also the decision making. They could make some decisions that is, you know, because you don't have a control as a parent. For example, if for whatever reasons, a child who's 16 just says, you know what, I don't want to take hydroxyurea, they've got their right to refuse treatment because they are considered adults. How have you ever experienced such where, you know, you've got this, you know, fight with the parents and the child saying, I want this, and the parents want something else, which is better for the kid?
Yes, so I think young people, when they have had hydroxyurea for a long time and the symptoms have disappeared or more or less been well controlled and they've forgotten about what pain is, and then they begin to think, well, my life is better than sickle cell disease, so I'm just going to party, I'm going to drink alcohol, I'm going to do all those kind of things. Don't bother me about taking these medications. And actually, sometimes they stop taking the medication because they've forgotten about the difficult pain that they actually were having before. And some of them is a real shock to realize that by not taking the hydroxyurea, they're actually less active. I mean, they're less kind of healthy. And then they find out that the symptoms are beginning to come back. So yes, you do find young people, particularly who want to find out who they are, who their identity is. And they want that identity to be different from what is imposed on them. And one of those things they impose on them includes the treatment, includes the hydroxyurea, includes even the transfusion program. So sometimes there was one day a young person basically brought her back, a box in front of our hospital. And I said, oh, what is happening? The father, who is a pastor, had said to her she will not do something. And then she felt very upset and she left. A young person also, he left a lot of hair. He'd grown a lot of afro, and the father said you should cut it. And actually that became a major kind of issue. And the things that people fight about are actually sometimes not the essential things. And I think that's why parents need to recognize there are certain battles that you can try to manage and not get yourself in it, because when you get yourself in those battles, it actually makes it difficult for you to win the war.
That's very true. But anyway, we leave it to you and the clinician board to make guidelines to allow parents to take charge at some point, maybe from 18 years old.
No, the guidelines obviously have to, I think now they're insisting that our guidelines should now have parents, patients on the panel to comment and to actually guide them. So it's not, again, no longer doctor, nurse, psychology, but actually we're working with families as well to develop those guidelines. Thank you.
Well, thank you so much. And I'm sorry, again, we woke you up quite early in London, but we thank you so much for this education, and we look forward to you joining us next year again.
Thank you very much. Have a great time. Appreciate it.
Everyone. We go through to the next session, which is a panel discussion on Hoover. So thank you so much, everyone. We'll see you there.